So thank you. My name is Rita Brandsma. I'm the lead for the Scaling Up Decentralized Education for Nurses and Midwives here in Zambia. I was meant to co-present this presentation with Mwanza Lubea Keti, but she's unfortunately unable to present today as she's homesick. But I have 10,000 behind me. I have a couple of our Zambian colleagues joining us here today as well. This program that I'm about to present to you was be made possible without the support of the Swiss Agency for Development and Cooperation, SEC, as well as Hilti Foundation and the Liechtensteiner Entwicklungsdienst. I hope my German's not too bad. Just to start off, I'd like to have a little bit of an icebreaker and invite you to open up your menti.com. I understand that it's commonly used in the global north. So I just want to get an idea with this icebreaker to get an idea of who the audience is, where they are, and what they're, in a descriptive way, using 2 words, describe the health professional status in your country or where you're based, and how that country is achieving universal healthcare. Are they there yet or not? And so if you put in the code in your menti.com, so you go to menti.com in your web browser, you insert the code 430302226, you should be able to see this question. And I have seen that 3 are connecting, so it does work. So that's good to see and encouraging. So without cluttering, it's a word cloud, without cluttering too much in text and lots of words. Is it a crisis? In what country? Or is it, at par to achieve universal healthcare coverage? I'm trying to get an idea of who the audience is and where we're at in terms of health professionals and achieving universal healthcare, because that is the topic of this presentation and the seminar. So I'm seeing that many are joining, but I have the feeling that people are still thinking maybe about what to put in. I'd love to see some words coming up, and this is a bit of a trial and error to see if, there we go, it's stretched. It's of quality, so I'm getting a sense that please also include the country you're responding from, so that we know which country is stretched and which country is in quality or has quality healthcare. Okay, so that was Switzerland. I'm guessing the quality is in Switzerland. There's a healthcare worker shortage. So I'm getting some responses, what I'm assuming from low middle income resource settings. It's underfunded. It's evolving. Okay, good. I'll wait for some more. I don't know, Amelia, how many participants we have, but I'm just trying to wait until we have at least 15 more responses before I move to the next slide, just to get a better idea. Shortages in Zambia, which I'll speak to. Underfunded, under-resourced. So these are common themes. I think Switzerland is a lucky country, and I think I'll speak to that as well. Let me move on. We have 3 Menti questions coming up in this presentation, so please keep your menti.com accessible for when they arise. Why human resources for health matter? They're the backbone of every health system, and it's particularly important to have an adequate supply of health professionals that are equitably distributed, but also that they have received and undergone a good quality training. And these health professionals are critical in achieving universal healthcare coverage and the Sustainable Development Goal 3, which is good health and well-being. In order to have resilient health systems that can respond to the most recent pandemics, such as COVID or non-communicable diseases and maternal and child health challenges, you need resilient systems. The WHO recommends a minimum of 44.5 doctors, nurses, midwives per 10,000 population to meet the SDG targets. And of course, by virtue of the profession, nurses and midwives form the largest group and form a very important part of the broader interprofessional workforce domain. Just an image here from Zambia. So key global findings from different reports, such as the State of the World's Nursing Report 2020 to 2025, as well as WHO's Health Workforce 2030 strategy and Global Health Work Network, there, as well as a reference from Global Health and Care Worker Compact and Health Workforce Support, shows that there's 58.3 million health workers globally. Their WHO estimates that there's a 10 million health worker shortfall by 2030 in meeting the growing health population globally. And obviously, most shortages are in low and lower middle income countries. And those shortages are pervasive to most cadres: nurses, midwives, doctors, pharmacists, clinical officers, even lab technicians and radiographers. There's a 27.9 million nurses globally that form part of that global national workforce, and 59%, they form 59% of the health workforce. And by just virtue of the profession, the majority of them are women. We also know from the report that there's a shortage of 5.9 million nurses, and there is just inadequate investment overall in nursing education, employment, leadership, and the urban-rural divide. There's also issues around active recruitment of health professionals from developing countries facing acute shortages even further, such as brain drain. What that looks like for nurses, and let me just mention that the Global Nursing Report was the first of its kind, so it's really amazing to see that the WHO has finally put nurses on the landscape in terms of documenting, the crisis in the profession. And as you can see here, Africa carries 25% of the global disease burden, but it only has 3% of the global health workforce, indicated by the red and orange here on the map. And the health worker density is around 14 per 10,000 on average, which is obviously falling very short of the 44.5 WHO recommendation. And the common challenges here is a weak pre-service education systems, low investment in-service training and continued professional development, limited faculty and infrastructure in health training institutions, and of course the brain drain and the out-migration. These reports also provide some recommendations and guidance into what to do next in terms of this crisis we're facing. And some of these recommendations are reflected here, such as improving data and workforce planning systems and leaderships to be able to monitor and track the progress or the challenges and barriers to getting the workforce to where they need to be, but also strengthening interprofessional education and collaboration relating to capacity, quality, the teaching staff, faculty. Also prioritizing primary healthcare workforces, such as nurses and midwives in the rural areas. They are the first point of care, and they're often the only point of care because there's such a shortage of other medical staff to support them. And a lot of work still needs to be done on prevention and promotion, which happens at the community-based intervention. And then, of course, we need to align workforce planning with epidemiological and service needs, making the training relevant to the context that health service providers are going to be operating in. So zooming in now from global Africa now to Zambia. This gives you a bit of an idea of Zambia's workforce, which is a human resource for health density of 12 per 10,000 population. And between 50 to 60% of these health workforce in Zambia are nurses and midwives. The disparity is predominantly 90% of the health professionals are concentrated in urban areas, which increases the rural-urban divide, even though 55% of the population resides in the rural areas. And the key challenges here are training capacity in rural areas, under-resourced skills labs, clinical sites, and faculty shortages. And a lot of training is centered around urban centers. And this is recent. This graph shows a little bit what the text is saying, or it shows it to a large degree and extent. This is data that we just recently collected as a midline. So we collected this in 2023 and now repeated it. And here you can see the proportions across the professions. that we collect data on. You can see the majority are registered nurses. To a lesser degree, you got the registered midwives. There are not enough of them. And this data, let me just clarify, was collected out of our 50 decentralized clinical placement sites that we are actively engaged in this intervention, which I'll speak to more about as we progress through this seminar. But it also shows, for example, that when it comes to trauma specializations in the nursing field, even specializations, specialists, physicians, the numbers reduce dramatically and are almost non-existent. Look at the trauma nurse, for example. We have 50 sites. There are only 16 of them. These decentralized sites are widely dispersed through the rural area. Trauma happens everywhere. But there's only 16 of them. Neonatal nurses, with a crisis as it is in Zambia, with morbidity and mortality rates the way they are, we only have 22 neonatal nurses at the time of data collection. Anesthesia nurses, generally better placed, but then it looks as though it's one per hospital. And then nephrology, all those specialties like nephrology, oncology, those things need to be, all those patients and clients need to be referred basically to urban centralized settings for specialized treatment and care. But it also means that there's very limited career pathways embedded within the rural system and CPD system. Another image just of our students here that we train. These are second and third year students. And now I'd like to again do a Menti on what do you think as the audience are the reasons for inequitable distribution in Zambia's workforce. Can you, even though you're not here with us in Zambia today, can you give me some ideas of, what do you think is causing this inequitable distribution? So you can go back to the same menti.com and I will start the Menti. And you should be able to link in with ranking what you think are the highest issues around this inequitable distribution. So this is a question asking you to rank, prioritizing what do you think are the biggest issues. I mean, they're all consistently across the board an issue, but what do you think is the biggest issue in terms of this inequitable distribution? I'll give you a moment to respond. It looks as though I only have 7 people who have joined the menti.com. So if that's indeed the case, I won't spend too much time here. So there's already some response coming in: limited career prospects, poor working conditions, low salaries, training opportunities, lack of housing, global recruitment practices. So people are starting to respond, which is really good. Obviously, poor working conditions are cross-cutting and interface with all the other issues that are listed. Poor working conditions is still number 1, though, even though 5 out of 7 that have joined the menti.com have responded. Interestingly enough, SolidarMed has done some research and together with Clinton Health Access Initiative. And lack of housing was one of the key determinants for retaining and attracting health professionals to the rural areas. There simply isn't housing to accommodate staff placed in rural areas. So that's really interesting. Obviously, all these things are contributing to the inequitable distribution. There's a growing external migration of nurses and midwives and other professions, health professionals to UK, Canada, Australia. I also know from an insider that Switzerland is also recruiting from outside of Switzerland. Loss of skilled nurses undermines local training investments, and it does affect healthcare delivery in underserved areas. And there is a WHO global code of practice that discourages active recruitment from countries facing critical health workforce, such as Zambia being one of them. It's also just a loss of investment when we're training health professionals, and the WHO's health workforce support and safeguard list flags Zambia as a critical source country. And brain drain continues to pay disparity, it causes pay disparity, lack of professional growth, and poor working conditions. So these are all equally co-contributing causes. Now I need to go to the next one. So core barriers to clinical education in Zambia. So what are the core barriers to actually train more health professionals? The current training model at a national level is very centralized. It's mainly centered around urban sites and mainly the capital, and larger sites such as in the Copper Belt or southern province, such as Livingston, and which leads to highly congested training sites because there's more students trying to be trained in those sites, and it leads to a diluted learning environment, and the quality is very compromised. It limits access to rural students accessing those trainings. There's fewer graduates that return to underserved communities if they've been trained in urban settings. The faculty development and investment in faculty in rural training institutions is patchy and inconsistent. There are weak interprofessional learning models, so multidisciplinary learning, they're very much learning in silos. There's a mismatch between training output and health system need. So what are we training, and is it meeting the demand? And we know that this also cuts with the ability for the Ministry of Health to actually absorb those graduates into the system economically. Then there's infrastructure, teaching aids and qualified lecturers are in short supply. Housing and student accommodation are core barriers, and as well as the high attrition due to the factors already raised in the previous slide. And then fragmented training regulation across the different cadres. So what opportunities do we have? There's opportunities for human resources for health strengthening, scaling up vocational centers of excellence, which I'll describe to you and present to you, as well as the decentralized education for nurses and midwives. We can leverage on e-learning and multidisciplinary mentorship and clinical simulation, addressing the rural-urban divide. The models that I'm about to present to you also have a cost-effective interventions. The return on investment is there. The opportunity to partner with global and regional human resources for health development initiatives is there, and investments in teaching infrastructure, housing, and student accommodation through social enterprise models are also there. And then there's an opportunity and a need to strengthen human resource for health planning through data systems. So digital transformation is key. So a little bit more on the model. So the training model, the decentralized education for nurses and midwives, is a training model that formerly was centered around this mother site college and hospital in an urban setting. So not only have we now focused on focusing on our attention on building the capacity of rural institutions, training institutions, so taking the focus to rural training institutions away from urban settings. Also within that rural training center, we're also decentralizing out to clinical placement sites that are hospitals, level 1 hospitals, big major healthcare facilities and primary healthcare facilities, to which the students are now rotating and experiencing each and every clinic for the aim is 50% of their training. And this is a 3-year training for registered nurse, registered midwifery, and public health nursing. And so we've had to shift from training traditionally to the decentralized training, which is a lot of change management that comes into play. We do this in collaboration with the Ministry of Health and the provincial health departments in each province, and with regulatory oversight from the Nurse Midwifery Council of Zambia. We've had to create positions that weren't formally there, such as a site link tutor, to act as the liaison officer between college, training site, or the theoretical college, and then the clinical placement sites, and make sure that student flow and placements are well regulated and the flow is done properly without causing congestion, coordinated and communicated. We've also had to train preceptors to receive those students. So what this has done is it increases access for rural and underserved population just by virtue of those decentralization and those satellite sites. It enhances the rural workforce retention because we're training our health professionals rurally. It strengthens the community-based health systems. It reduces the urban migration of health workers, so they're less likely to migrate to the urban areas because they've been trained locally and they're from the area. And it builds local capacity and resilience. And this is all very much aligned with the Zambia's Human Resources for Health strategic objectives. Now, the co-program, which is led by Mwansa, is the Vocational Centers of Excellence. And these are provincial training hubs to which we're building. We're in the process of building 6. We have completed, I want to say 4, but the 4th is still halfway construction. And what this does is we take provincial teaching hospitals and provide them with a training hub in order to be able to offer continued professional development there within their locality, rather than having to come to urban settings to get continued professional development opportunities. So making training and the learning environment there where it's most needed. And these VCEs have an e-resource room in order to access blended learning opportunities. And they have 24 stations, a skills lab with fully equipped mannequins and models to practice skills in and do clinical simulation, as well as a lecture hall that can accommodate 150 students at a time. And these VCEs are also multi-cadre focused, meaning that they're accessible by all the cadres, and we're proactively supporting a multidisciplinary collaborative team, interprofessional team work around patient care, around patient-centered care, to be even more specific. Now, this is our map. This is our interactive map. I could give you a demonstration of what this map gives in terms of details, but what this shows is our scope, our geographic scope, and our presence. So all those points are where SolidarMed is supporting a clinical placement side. They're the training institutions we work with, and they're also the vocational centers of excellence. And if you look at just the colors, for example, these purple colors up here, I don't know if you can see my mouse, that's the training college for Solowezi, and they refer their students as far as Kabompo, which is a site down there. And so these are the cluster of satellite clinical placement sites that link up with that specific training institution. And we have that within each province, and we're in the process of increasing our clinical placement sites as the student numbers increase. Each data point also has data available to them. So if you click on the GPS, the data will come up saying what the site is, what their student capacity is, whether they have student accommodation, how many preceptors, mentors are trained there. And we continuously update this map with every round of data that we collect, ensuring that our data points are accurate and up to date. So how does decentralized education work? We promote team-based learning and interprofessional clinical education. And just end of year 2024, we in our pre-service nurse midwifery program have 5,395 students at the end of the year 2024, and have worked with 434 in-service faculty, as well as mentors and preceptors. We have those rural training institutions that are 10, one in each province, with their related satellite clinical placement sites 50, but soon to be increasing to 61 this year. And the objective is that the 50% of the students' time, especially for nurses and midwives and public health nurses, is spent in clinical placement sites. Then there's the multidisciplinary preceptorship approach, which is led by our vocational centers of excellence, to which doctors are involved, clinical officers, medical licentiates. And just in all those VCEs that are now functioning and operational, between January and May, we recorded 15,640 learning encounters. And so you can imagine the scope and scale and the potential impact of this intervention in terms of improving the way that students are taught, but also the way that service delivery is done. And we are in the process of evaluating the impact this year as well. Then there's the e-learning integration, so establishing a national e-learning platform. This is particularly under the Nurse Midwifery Council of Zambia. They do not have an existing platform for pre-service education, and so we're in the process of developing an e-learning platform centrally that will be regulated centrally. But we're involving those rural colleges and subject matter experts into the development and design of the content, especially with the priority of focusing on the first year's students of the registered midwife, nurse, and public health streams. We have strong partnerships with regulatory and regulators and the ministry, as well as provincial health offices, where the provincial nurse officers sit, who lead on continuous quality improvement. And then we have strong relations with the superintendents from the local hospitals themselves, as they are the managers of the in-service crowd that mentor the students coming through. We address the access and equity across all cadres and empower provinces to train and absorb local talent. Now, a force field analysis. I've spoken a lot of praises on what we're doing or trying to achieve to do, but of course there's challenges. And I just wanted to reflect on what are the forces against change, and whether you could all maybe input into what do you think are the areas that we are particularly challenged in when we're trying to decentralize the way clinical education is taught. What do you think are the issues around that? So I'm starting the Menti now. What do you think are the biggest barriers to scaling decentralized nurse education, health professional education in underserved areas? And I'll just pause here as you reflect. And I'm just doing a time check, but I think I've gone a little bit over time by the looks of things, but hoping to get some responses. Funding, yeah, transport, accommodation, lack of preceptors, funding, limitations in infrastructure, teachers available, updates take long to reflect in curricula, high cost of transportation. Yeah, so just a response, of course, with the decentralized training, especially under the nurse midwifery part of the student program, the bottlenecks are in the institutional capacity to send out their students. It's a logistically very demanding exercise to be sending students out continuously to those different sites. They have limited transportation vehicles. The vehicles that they have are very poor in quality. Then there's the issue of housing them, the students themselves, putting them in safe accommodation. Obviously, they're doing shift work when they're in clinical placement. And so now, for lack of institutional housing or accommodation, they're now in the community and not always in standard quality accommodation. And then teaching infrastructure itself is very limited. So although the decentralized training model is super cost efficient because we're not building colleges from scratch, which would cost so much more money, we are needing to supplement existing infrastructure with a skills lab or whatever they lack. Some colleges don't have a lecture hall that accommodate all their students. They don't have an e-resource room. And so we're supplementing it, but at least that's a lot more cost efficient than having to build it from scratch. And then, of course, these vocational centers of excellence should be and need to be in each province so that every province can benefit. But it is as the funding allows. Obviously, teaching capacity as well, although there's a lot of drive and motivation, just the opportunity for capacity building is far more or less when you're in the rural areas. The connectivity, the ICT to support e-learning is also very challenged. There's a lot of barriers along the way, but there's also a lot of forces for change that promote and support, that can be drivers of change and that we can leverage off of as well. So moving on, interventions ongoing now for us, we are focusing on leadership and management. Part of that leadership and management is biannual supportive supervision with tailor-made tools developed in digital tools, may I add, developed in Kobo Collect, which is a free software that we use, and that's encouraging a reflective, continuous quality assurance cycle. And we involve our senior leaders in data review of that data. So we have a lot of data points that we collect. We're scaling up the decentralized training model nationwide, and so these 10 institutions are lead institutions. And obviously, with the expansion of the decentralized training model, we've already found that a lot of non-SolidarMed supported colleges are sending their students to the supported decentralized sites because they know that they're getting the mentorship that the students rightly deserve. So that web of clinical placement sites is only needing to get bigger because now we've got multiple colleges and you don't, again, want the congestion to take place. And then, as I mentioned before, invest in supplementing the rural training infrastructure, accommodation, and skills labs. So with thanks to SDC, for example, 5 of our 10 colleges are benefiting from a skills lab, fit for purpose for that specific college. In addition to that, teaching spaces at decentralized sites, because at the moment, those decentralized sites, the preceptors have nowhere to bring the students that they have for a little session, a clinical simulation, a case study. And so they're building teaching spaces that can accommodate small learning sessions to enhance the learning environment. We're working on the e-learning platform for blended learning options. There is a lot of opportunity from the stakeholder engagement we did and mapping out the stakeholders and finding synergy and leveraging off of that. Investing in teaching faculty and preceptors through a multidisciplinary approach and clinical simulation has been evidenced to be where theory and practice align. And then aligning curriculum with community health priorities. So, for example, public health nursing is a very young program. So we're looking at evaluating it, ensuring that it aligns with the Zambian health priorities in the rural sites. Strengthening policy support and funding mechanisms where we can, and then implementing strategies to ensure retention. So incentivize rural service through accommodation, career pathways, and continued professional development. And there's a need to improve the working conditions as a whole through continuous professional development. As a conclusion, health professionals are central to achieving universal healthcare coverage and health equity. Addressing education access and workforce development and distribution is critical. Decentralized education is practical, it's a cost-effective and scalable solution for Zambia. And investing in health professionals is investing in a stronger, fairer health system. Addressing retention is also key to sustain investments in education and decentralization. Without these measures, rural training will not translate into rural service.